afternoon. My name is Fawn Lopez. I'm Vice President, Publisher of Modern Healthcare magazine. It is truly a privilege to be here, and I thank Matt Chambers, Nikki Mitchell, and Baylor Scott White for having me here today. And thank you for joining us at this session. We're here to explore how technology will enhance the experience and outcomes of patients, consumers, and healthcare providers. Enhanced experience and engagement of the consumers, of patients, are vital to healthcare as it makes it the transition to value-based care and population health. There are many issues to cover today, from which technologies hold the greatest promise to how some technologies have missed the mark. Strategies range from putting the patients at the center of tech decisions to getting feedback about technology choices from members of the care team. I'm here today with 3 seasoned veterans in the design, implementation, and evaluation of technologies with the potential to enhance the patient experience. So we'll spend a couple of minutes with each of the panelists for them to introduce themselves, about 30 minutes, 35 minutes for discussion, and then we'll turn to the audience the last 15 minutes for questions. So without further ado, let me start with our first panelist, Matt Chambers. Matt, please share with the audience your organization, what you do. Describe a technology that you or Baylor Scott White has implemented, and the role of technology in enhancing the patient's experience.
Okay, thank you very much, Fawn. Good afternoon. So I am Matthew Chambers. I'm the Chief Information Officer for Baylor Scott White Health. Quick show of hands, and by the way, this is the first time I've ever done a South by thing, so if I screw it up, y'all take it easy on me. So quick show of hands, how many of y'all are familiar with Baylor Scott White Health? Okay, so probably a lot of local folks. So we are the largest not-for-profit healthcare system in the state of Texas. Thousands of physicians, about 48 different hospitals, hundreds and hundreds of access points. But the most important thing, if you'll go to the next slide here, for you here, if you're feeling poorly, let me put in a shameless plug for our brand new Sexiest Clinic. It's right down. It is, according to Google Maps, it's a 4-minute walk from here. It's at the corner of Trinity. It's right across from the Four Seasons. It's actually in Cesar Chavez. It's got a lot of signage up, and this is actually the physician that you're most likely to meet there. I think she was doing a panel today. Her name's Dr. Sky Clark. She is not a professional model. She's actually a physician, but she has become the face of the Austin clinic. And this is actually a real room. So that's actually our clinic room, and that's what she's looking at there is those are real. Well, those are not real patient specs because that would be a HIPAA violation. But that's a real working exam room there. And so one of the things that we've done, and we're really focused on in technology right now at Baylor Scott White Health, is patient engagement and, let's say, simplifying, beautifying the consumer experience in healthcare. My personal theory, and I guess I should start off by saying these are my opinions, do not necessarily reflect the official statements of Baylor Scott White Health. But I personally think that healthcare is one of the worst industries in the world to navigate. It's incredibly complicated, just the basics of trying to find a physician, get an appointment. We have so much to learn from other more consumer-friendly business models. You know, when you're looking at financial services and airlines as examples of how you can better your customer service, you know that you've got a lot of low-hanging fruit. And so we're really excited about what we can do. The reason that when we first started the panel, I'm a shameless science fiction fan, and what I've noticed, or at least my personal opinion is, things that, 1984, every Stand on Zanzibar, everything that's been kind of a foretelling science fiction novel, it ends up being true. And so we started thinking about, what are the technologies that you see in science fiction that we're starting to implement, and we'll talk a little bit about that, but we're going to try to make a balance between the things that we're already doing, like some of this stuff today for patient engagement, and the things that we see coming in the next couple of years.
Next, please.
All right, so my name is Ashwin Pushpala. I'm the founder and CEO of Sano. We're a startup company in San Francisco working on a technology that allows people to continuously understand what's happening inside their bodies. We make a transdermal sensor. It's a little patch that you can wear on your arm, continuously monitors various chemistries in your body, and we're starting with sugar as the first metric that we're monitoring. Sends that data wirelessly to your mobile phone, and we are building an analytics platform around that to help you make better decisions about your diet and exercise and nutrition. So basically, this is a quick summary of what we do. There's a patch that you wear on your body, sends the data wirelessly to a phone where it's presented in a really easy to understand visual, and then there's some analytics and a couple suggestions that you can see in a real-time basis, and then ultimately share that data with a family member, a provider, etc. And it's a pretty complex electronic stack. We actually build the sensors from silicon, and so we're a semiconductor company, and we've built electronics and a piece of software that sits on top of that. And so we are kind of, we were inspired in some form by the tricorder and trying to understand how to detect various ailments before they happen, understand the changes in someone's metabolism over the course of time so we can prevent the onset of the diseases, particularly ones that don't have symptoms that are very, very easily seen, things like diabetes, heart disease, kidney disease. And so we're starting off with making the diagnostics and the testing portion of what is in the medical system today more accessible and easier and painless for the end consumer.
Mark.
Hi, my name is Mark Ralston. I run a product design agency called Argo Design, and previously I was the global head of creative for Frog Design. I spent my last 20 years there, and we serve a lot of industries, and healthcare is one of those. And amongst all of that, one of the things we see in a lot of these industries is this increasing quantification of the world around us. And when we imagine that, so my job often is to look at the future and to imagine, we imagine this increasing ability to not only understand better the world around us, but to understand ourselves, to measure and quantify ourselves. And what's to me so interesting about that is not so much looking behind us, but being able to predictively model our bodies and the decisions we have in front of us, and to be able to progressively understand the implications of that. How many of you are familiar with the ODB2 bus in a car? It's a really brilliant little technology invented in the early 90s, and it's a common bus, basically a common ontology of the car. And that allows anyone to plug into any manufacturer's car, a modern car at least, and read what's going on in it. And what we imagine, what we're seeing slowly occur in this industry is essentially that for the human body. A common understanding about the metrics that are possible to read from it, and what that might mean for behavioral modification or, of course, more extreme levels of understanding of the body.
Thank you. So let's start with a general question. And so in healthcare, we talk a lot about how we need to engage in innovation and transformation. But healthcare is lagging so far behind many other industries. Why do you think healthcare is so behind in the digital transformation? And how would you suggest to the healthcare industry to accelerate the pace of change? Ashwin?
Yeah, go
All right, I guess I'll start. I think we were talking about this a little bit as we prepared for the panel, but the healthcare in and of itself, there are certain standards and practices that providers and health plans use to make sure that they're operating efficiently and with the best intentions of the patient in mind. And so one of the things that technology does is it perhaps can change the way that these practices are done. And so inevitably, there's going to be a reluctance to use a new technology if it does change the workflow of a particular physician, if it does change the decision-making process for a physician. And so there is a little bit of a reluctance to make a drastic change. And so as a result, smaller changes are made on a much more regular basis. And so we may be behind other more high-tech industries from that perspective, but changes are being made. And I'm sure Matt will talk a little bit about that.
Yeah, excuse me. Yeah, absolutely. So healthcare, my personal opinion, and Fawn supports it, so it must be right. So my personal opinion is one of the reasons why healthcare lags. One is the change paradigm. No one really likes to change the way they do things. Even disruptors don't like to really be disrupted. But at least in my experience, healthcare is probably one of the worst when it comes to changes in workflow. The word workflow, I've been in other industries, I've only been in healthcare for about 10 years, and I never heard the word workflow so much until I got into healthcare. And when you go through, most physicians, and this is something a physician was telling me, talking about the other day on a panel, it's really kind of a mentorship. It's like an apprentice style of work, like a blacksmith or whatever. So they're trained a specific way, and it's very, very respectful of the past. And it's not necessarily very embracing of change. It's very embracing of data and analytics and evidence-based medicine and all is about that. So that's one primary reason. The second reason that I think the healthcare lags so much is it's expensive. So if you look at where healthcare came from, if you look at our hospitals that are, our companies, our two healthcare organizations, when they merged, they were both over 115 years old. And if you look at where most hospitals started, they started as sanitariums and things of that nature that were, for the public good, that were maybe founded by nuns or what have you, and they didn't have two nickels to rub together. And so that's all in the DNA about being very, very cost effective. Every single dollar goes directly into patient care. So somebody the other day asked, you keep saying you're not-for-profit healthcare. What is not-for-profit healthcare? I was like, well, our profits or our operating income in excess of our costs goes directly back into our healthcare. It goes into research. It goes into free care for our populations. Whereas, our brethren that are for-profit, they have shareholders. So while they can talk about their primary mission is to make people healthy or to keep people healthy, I would counter that their primary mission is to enrich their stakeholders who have their common shares. So we're a little bit different in that regard. And so the monetary reasons, back to the question, the monetary reason is really one of the reasons why we lag. The things that we have to do in healthcare are so heavily regulated and so complex that they're just inherently very, very expensive. You hear a lot of these horror stories about $100 million EHR implementations, and everything we do is relatively expensive, and it does cause us to lag.
Yeah, I think this is an industry where you can't kind of just screw around. You've got to get it right out of the gate, and it doesn't exist at the same scale as a lot of consumer technologies.
Right.
Interesting enough, I had this, a lot of our clients are saying that same thing, but in the late 90s, I had a meeting with the Sony robotics division, and they said something really profound that I keep drawing back into this industry. They were working on this little toy robot. If you guys remember the Aibo robot, they were convinced, and I think a lot of the manufacturers in Japan had convinced themselves the way to build a successful robotics industry, they had this really long view, was to first start with toys. start with these trivial opportunities that didn't have to be exactly right. The IBO could be kind of clumsy, but they could prove out the infrastructure, they could prove out a lot of the technology, and progressively move it into more mission critical, more high expert systems. And we've seen that happen. And when I look at this industry, I look at what Sano's doing, entering the consumer market first, proving that out, and eventually making the case for more mission-critical uses of that same technology. I look at what's in my watch. I have 6 months now of my heart rate. All day long, every few minutes, it takes a sample of my heart rate, and I have a perfect mapping of that. Now, the industry hasn't yet woken up to the possibility that I might have a relationship with my doctor through that information, because I don't think the trust is there yet. But we're close enough that this should be on the table as something that very soon doctors do look at. And I develop a relationship with my doctor where I have an ongoing relationship, an ongoing checkup, and not just simply the moment I'm sitting there in front of him, but a relationship where he understands my heart rate and maybe, hopefully, many other metrics over the course of the year. And those checkups can be a much richer conversation at that point.
So we're going to talk about the patient experience in a minute, but I want to follow up on this. So how do what needs to be done for healthcare to accelerate the speed of change?
Well, I'll kick it off here. I'll say from an operational perspective, it's hard because, as Mark said, this is an industry, you've got to get it right. So we talk about different things, at least in our technology, and we have to focus on areas that it's okay to do experiments, right? We can't do experiments necessarily in life or death situations, but we can in the customer relationship. So, one of the things we're doing is we're looking at other industries and other things that people use, and we try to apply design thinking and think about everyday experiences we have, right? So a couple of years ago, our board kept saying, what's the Uber of healthcare? What's the Uber of healthcare? What are we going to do? And my response is, I don't want to be the Uber of healthcare. I really want to be the Amazon of healthcare, because as Mark talked about, this quantification of data, we know so much about you. And some people worry about privacy, but the whole point is we have so much data about you. The things that Sano's doing, for instance, these are really, really important, because if you look at the 50% of the healthcare costs in the U.S. are driven by 5% of the population. Those folks are very, very expensive, and there's very little we can do. But that next 15%, our goal, the next 15%, if you look at striation, you've got your invincibles down here, and they're responsible for a very, very small percentage of our costs. So right now, the folks that wear the Fitbits, that are walking a lot, they're not the problem, right? Or they're not the cost in the healthcare. They're very, very proactive. So what we've got to do is find ways to engage with those folks that are about to move into the most expensive way. And if we have that data, if we have that Amazon-like experience, because we are a payer and a provider, and we are, kind of a, I hate to say this, I'm sure it'll get tweeted and misinterpreted, but we're kind of a benevolent big brother, right? We're watching you. When we have your data, and we have your best interests at heart. And so we want to engage you, we want to use your data to help you be healthy. And I think what you're going to see, there's only a few ways I think we were joking about this this morning, there's only, in my mind, about 4 main drivers on how you impact people's behavior. And 70% of health outcomes is driven by your behavior. So what can we do with technology, things like this, to get you to change your behavior? Not just monitoring it, but change it. And so I think you can appeal to people's brain, their rational side. You can appeal to their heart if you can tug on their heartstrings. I think the most important one is you can tug on their wallet. The fourth, I think, is people's relentless need to procreate and carry on the biological species. We're not going to get into that one. The third one, though, the wallet, what can we do? If we can impact the way that you behave, what you're going to start seeing, and you've already started seeing this, your healthcare insurance is probably in the next couple of years going to be priced like your car insurance. As Mark talked about, that onboard diagnostic in your car, you get a discount if you drive safe. So we know there's social determinants to health. If you don't drink to excess, if you don't use tobacco, if you practice safe sex, if you wear a seatbelt, and you eat healthy or exercise in proportion to your diet, we know if you do those things, you're going to have better outcomes in your health. And so we believe that what you're going to start seeing is people are going to get insurance priced that way.
Anyone?
Yeah, I think the thing I would add there, in order to accelerate the growth and adoption of these types of technologies is to put it in a way that the folks that actually deliver and pay for the care, which are providers and plans, can actually make use of it. So for us, we monitor glucose continuously. Typically, this type of information is only used by type 1 diabetics or really, really severe type 2 diabetics that need insulin. But it can be used in a variety of other contexts. Let's say, for example, someone who has prediabetes, who is in that second 15% of the population that could be very, very expensive to the system very soon. But providing data and evidence to suggest that those folks would gain a lot of value from using our product is what will allow our technology to be adopted more quickly by the system. So that's what we're doing. We're running studies that show that people use our product end up becoming healthier in a shorter duration than someone who doesn't use the product, in which case it makes it a much, much easier decision for an organization like Baylor Scott White to say, okay, we'll adopt that. Even if it is an experiment, it's with a lower risk population, but it actually is shown to provide a more positive outcome. So we're doing this in a variety of categories, not only showing that the outcomes are better, but there's actually financial and monetary impact to that as well.
Any thoughts, Mark?
Yeah, I mean, I want to be able to model my future. I want to be able to understand what's going on with my body. I think one of the things that's necessary when products like this, as they begin to make it into the market, I mean, there's two different vectors that are really important. One is the validation, sort of the normalization of that data, so that the medical industry progressively trusts it. They trust your device after it's been out in the market for a while, and they start to adopt it in more mission-critical uses. The second is a shared ontology, so that multiple devices, because the story of my body isn't simply one sensor and its story, but a series of these devices, a series of sensors being able to tell a much richer story. So I'm looking for the industry to be able to bring these different sensors, these different data points together into richer stories, so that when we look at the idea that that person about to eat the hamburger, trying to look at his future, his immediate future, and the impact of that, that can be measured on multiple dimensions, not simply glucose, not simply heart rate, but any number of factors that will predict his ongoing health.
Thank you. So we're here to talk about technologies that will enhance the patient or consumer experience and engagement. What, in your opinion, how would you define the patient experience? What are some of the parameters there?
I think we like to say it needs to be invisible. I mean, technology right now is kind of a heavy load for all of us. We spend a lot of time staring down at little black boxes. Wearing sensors is a bit of a fashion statement right now, so it works on that level, but if it doesn't match your fashion sensibilities, then it's onerous, right? Wearing a Fitbit says, hey, I'm curious about my own body, I'm trying to improve, but it's also a piece of technology you've got to wear on your body, and it doesn't look like the rest of your jewelry. We need a sensor regiment and other means of quantification that aren't a technological overhead in the rest of our life. I think that's a huge bridge. The cost factor is a bridge, the trust in it's a bridge, but design's role and sort of the evolution of the tech is to sort of get it out of the way to where it can be part of our lives, but not something we see. And you should show them what that starts to mean, because you're wearing an example of where this can go.
Yeah, I mean, our product is meant to be on that borderline of being able to show it and being visible, right? I'm wearing a patch and it's on my arm. Actually, no, it's on this arm. See, I didn't even notice it. But it's really small. It can be hidden under clothing. It can be worn in multiple locations on the body, so that it can be flexible to the patient's experience and their preference for how they tend to wear their clothing. In terms of the patient experience, one of the things that we started talking about earlier today is that the patient experience is always negative. It's you're only going to the physician when something is wrong. You're never going there when things are going well. And so in order for it to be a better experience, there needs to be an interaction with the healthcare system when things are steady, when things are great, and so that we can avoid those really, really adverse events that we only solve for with the healthcare system today. That comes up in the way that we actually pay for healthcare, and we'll talk about fee-for-service later, I'm sure. But
Hopefully we don't.
Hopefully we don't. Actually, we said we didn't want to talk about that. So, but I think it's about having that experience start from when you are healthy or when you are on the borderline of not being healthy, as opposed to when you are over that hump and something needs to be done immediately.
Yeah, I think what we're hoping is the patient experience changes drastically in the coming decade, right? So, one of the things that Mark and I connected on is I think that the best interface is one you don't see. The best interface is invisible. And so they talk about, my vision, what we're trying to do is, what are EHRs going to be in the future? Because right now, physicians hate them. Nobody likes them. They're very onerous, but they're very, very useful to drive that transactional data so that we know this year was your condition, in 6 months this was your condition. You need that transactional data to build those analytics around populations, around population health. But my vision is in the future, the EHR is invisible. It's the heads-up display in Iron Man, or it's the computer in Star Trek, tea Earl Grey hot, and it hears you, it thinks, it's got natural language processing, and really we've got a lot of those components, but that is a very, very expensive thing to test, pilot, and build, but it's the type of thing that we're working on. I think what you're going to see in healthcare is, you talk about the patient experience, it's always been very, very provider-focused. You come see us on our schedule. That's going to change because we're seeing disruption in healthcare. So Texas right now is the last state that has some restrictions around, everybody has some restrictions, but Texas and Arkansas were the last two states that had really onerous restrictions around video visits, telehealth visits. And Arkansas just let theirs down, and ours is about to go down as well. And so we're seeing massive disruption. So anything that, one of the things that I like to look at is any time that you can take the meat space out of a transaction and it can go into quote unquote cyberspace, it's about to get disrupted like crazy. And so there's really not a lot preventing your healthcare from being offshore to India, other than when people need to see you and regulatory requirements. So whenever you see regulation as kind of an artificial barrier to disruption to an industry, you know that it's in trouble. And so I think we're going to see more and more of that. What's going to happen in the next 10 years is you won't go into the doctor, right? You'll have, if you're diabetic or pre-diabetic, you'll have a set of sensors, and they'll be constantly connected, and we can constantly be monitoring. And what we're starting to see now is you're starting to see things that look kind of like a NORAD or a air traffic control, where people are constantly watching the at-risk populations. And so I know on one of our panels earlier, there was one of the things called Proteus. It's basically a pill. You can take it, and we know when you're adhering to your medical protocols. One of the biggest causes of readmission is just not adhering to your discharge instructions and your medical protocols. We can watch, and we know you've taken your medication upon discharge. We can keep you healthy, and we can watch those things. And so I think that's what you're going to see is, frankly, there's going to be too many hospitals, I think, other than the end-stage patients that are incredibly acute, or transactions for procedures. But largely, the goal of healthcare is going to be really healthcare and not sick care, as it has been in the past.
So essentially, what you're saying is that technology will change the way you do business and who you are as providers.
I hope so.
And there will be less or maybe no hospitals at all in the future.
Well, I think...
How does that work for an industry that is so, it's built upon the more beds,
Yeah,
the more hospital rooms,
it's changing,
the better.
right? It's absolutely changing, and that's the problem with healthcare. I mean, I don't want to. I say I don't want to talk politics. The reason that the ACA is so hard to repeal and replace, in my opinion, is it's pretty freaking complicated to get it right. And a lot of us lost our shirts on the ACA when you've got those. You saw all the payers in Texas that were here on the exchange. They all pulled out largely. I think Oscar's staying in San Antonio, but largely the exchanges are now vacant because they're really, really hard to get right. Payer plans require populations. Like, imagine the business at Vegas if everybody that went to Vegas won and nobody lost. Vegas wouldn't be there anymore. So health plans need the same thing. They need the invincibles. They need the people to balance out the people that are driving up the cost of healthcare. And those folks, the invincibles, didn't enroll in the ACA. When you're only going to get tabbed, what was the tax burden, like $50 or $20 or whatever? If it's not more expensive than the cost of care or the cost of insurance, you're not going to do it. But yeah, I think to your point, to your question, I think we're going to have to change because our cheese is being moved. We're largely seeing more and more of our income shift to a pay for performance as opposed to a fee for service. I'm going to get paid, or we're going to get paid for what we achieve, not for what we try to do. If every time you come in, I order a lab test, I get paid, that's not a sustainable model, and we're seeing it largely go away.
So I'd like to hear from the two tech.
I think if you lived in a hospital, you'd think everyone in the world was sick because hospitals only see that side of the human population. I think when you look at the future of it, you need to see it, healthcare, as a sort of polarization where there's a greater amount of care for people during the healthy phase. And to me, I liken that to the way we look at insurance. You look at insurance populations, you need a vast healthy population inside of the insurance pool to take care of the sick population. When you look at this increasing technification and digitization of healthcare process, you need a healthy population that you're quantifying and understanding in order to make better sense out of the sick variables inside of that. And that's before someone goes to the hospital. That's life care. The opportunity to understand how people within a population are quantifiable. Here's a great anecdote. I work with a company here in town called Cognitive Scale, really badass AI-based. They call it Cognitive Systems based company. And what they do, amongst a lot of things, is process large troves of data to find what they call insights within that data. So it's not necessarily, when you use the analogies for interfaces, you think like Iron Man, great analogy for an interface, but that's a moment where you're asking a question. You're looking, where's the enemy in the case of that interface. But you have to think a more valuable example is this background processing, looking at the vast population and looking for moments that someone's not even looking for. So the computer, in this anecdote, the computer is processing through a very real population in a healthcare system. And this week, the pollen count goes really high. And we have inside that population a small sample of that population that has a very poor record of showing up in the emergency room with an asthma attack. They've been there several times. We have that record. We also know that their insurance adherence is pretty low. They've been on and off. And so they, for all of these variables and any number of other variables, they have a high likelihood of showing up in the emergency room this week. We can reach out to those folks and save not only a ton of money, but help save them from a potentially disastrous asthma attack. And you can imagine any other health condition where you take a healthy population, you take this statistical lens, and you're able to change the equation from a better emergency room to a better sort of life management protocol.
That's cool. Ashwin, so share with us your vision or what you think the consumer or patient experience look like 5, 10 years, 20 years from now.
Yeah, I think the two of you touched on two aspects of this future of healthcare that I think are pretty important. One is data and actually having an understanding of every patient's tendencies, risks, et cetera. And then the second part is the incentive to actually put that data out there. So right now in the healthcare system, the people who are the healthiest have really no incentive to be a part of it, right? You're just paying into something that you're not going to end up using if you're a very healthy person. If you flip that on its head and said, well, those healthy folks, the collective data from all of them could be very valuable to figure out where those changes in the health status of a person happen over time in a longitudinal view. why not potentially pay those people to be in the healthcare system, to give access to their data, to their information, see how it changes over time, because that data itself and the insights that you can collect from that data will be more valuable down the line. So ultimately, the healthcare system only works if we're all a part of it in the financial model that we're thinking about today. And so I think that in the future, that's how we get the folks who are in that invincible category to be involved in the healthcare system.
Okay, so I'm going to shout out some popular technologies and ask each of you to share your thoughts on the technology's ability to transform patients' experience. And make it quick, because I've got a long list.
It's a lightning round.
Yeah.
Buzz in.
So, artificial intelligence.
Finding the unfound.
Yeah, I think what.
Needle in a haystack.
Yeah, you're seeing, there's okay, I'll make it really quick, but yeah, exactly what you're saying. Just the ability to drive insight where it's just noise today.
Agreed?
Agreed.
Okay.
No, he's wrong.
Virtual reality.
Well, I think it's going to be very useful in the areas of healthcare where we need to take a look into how the data is going to change over time, and how the experience of a patient and the existence of a patient is going to change over time. And so as we look at longitudinal pictures of patients, that's how it's going to be important.
I think the most interesting thing we can do here is around mental health. So I've been reading some studies about soldiers who have PTSD, and they're doing memory implant therapy on them, basically retraining them. You know, you didn't have a traumatic experience. This is the experience you had. I think VR has the ability to play a major role in things like that with PTSD or people with mental health challenges in the future.
I don't know if it's healthcare, but it has crazy possibilities in surgery. Basically, the surgeon will stand inside your heart looking around, and through robotic translation, basically walk right up to that valve and operate on it standing there. And it's those moments that I think will be the most profound in VR, but they're going to be few and far between. Yeah. Super high-end shit.
Augmented reality.
Augmented reality, that's since my mouth was open, basically it's the interface that brings us that quantified world we talk about a lot to the moments that are most useful. Pulling your phone out, pulling a tablet out, your laptop, those are interruptions, and to be able to show that data that's low a level enough that you need to view it while you're doing something else. I mean, that's Mark Weiser said in a famous statement, the purpose of a computer is to help you do something else. And AR is, you might say, the final end game in that idea. So.
Yep. I think the same thing, similarly to what you said earlier in surgery. I think in the operating room today, we've seen the advent and decline in the consumer world of Google Glass, but it's being used in the hospital with great success. And so that's because people who are in the operating room, people who are physicians that are treating these patients, need to view a lot of information at a time in order to do their job well. And so you can either have a number of assistants or nurses in that same room telling you that information, or you can have a tool that allows you to see it in real time and make those decisions appropriately.
Anything else?
Yeah, I think the augmented reality is really the reason why I first started talking to Mark. They're doing some really, really cool things there. And the Google Glass is a perfect example, I think. I think it probably less for patients and more for our providers. They're just constantly inundated with data. If you look at the condition of a patient, especially in an acute setting like an ICU or whatever, having an augmented reality, the Google Glass, the way to access that stuff. So, like I personally, I'm waiting. I'm going to eventually have to have my corneas replaced. For cataract surgery, I can already tell. The physicians already tell me, and I'm hoping that by the time I need to get it done, we're going to be able to have implantable lenses that have the heads-up display like a Google Glass.
So all of that sounded really cool and exciting. So how long will it take before it is available, accessible, and will have an impact on everyday patient?
I'm a big William Gibson fan, and he gets credited with this quote a lot, that the future's already here, it's just not evenly distributed. So in some places, these things are already happening. There are use cases. You know, there's a company in California supposedly that has an AI agent on its board. You know, so and I can tell you, it probably does a better job of analyzing data than some board members. But you know, that's my thought.
I would argue it's already here as well.
Yeah, I mean, if you eat something, your device is going to tell you in a few minutes the glucose impact to that. So it's on his phone, and so he's just one interface away from a sort of persistent understanding of, at least at the sugar level, the impact. I have sort of a wrist turn persistent understanding of my heart rate, so I can see the impact of any kind of level of activity. And you know, anyone with an Apple Watch does have that if you download that app. That's quite a leap from only 5 years ago.
Yeah.
And so another 5 years, similar kind of linear equation of invention. It's pretty easy to see. It's not too far away. Now, adding it all up, I think the industry is a lot slower than the rate of the invention of sensors, the rate of invention of affordances, you know, different kinds of interfaces. And to me, that's one of the points of anxiety, is the sensors are going to pile up on a table and somebody's got to create the ontology, the trust layer, so that we can put those things to work.
Thank you. So I have a couple more items on my list. Telemedicine and virtual care. We know telemedicine has really made an impact in healthcare. So in your opinions, what are the technology's impact on transforming?
I'll tell you what's happening today in our system is you know, everybody talks about video visits and FaceTime in your dock and all that. The uptake on that, where that has been rolled out, is actually very limited. What we've seen huge adoption of is asynchronous telehealth. So the equivalent, I mean, everybody's out there tweeting, Snapchatting, whatever. You can do that with your dock now. So, we're starting to see more and more bots. You know, I know there's a South by bot. I'm going to play with it here in a little bit and ask it where to go for barbecue and see if what it says about Franklin's or, you know, whatever. But in the future, and what we're doing today is you can send a message, and we can treat a lot of things. I think we've done thousands of these visits, I know, in our central division, and it's stuff like UTIs and you know, simple, you know, earaches and things like that, especially if you have a chronic condition, and we can dispatch a script for you, and in some cases even deliver it to you, and it's all over text. And to me, that's changing the patient experience. That's going from the model of you have to get in your car, you have to take off work, you come down to the physician's office. Instead, you just text or, you know, send in, and in some cases interact with a bot, you know, once we get through the regulatory requirements. And that's here today.
From my perspective, which is as a patient, I've already seen this impact my life. I think, you know, as someone who travels a lot but does trust my physician, right, and wants to interact with my physician that I have a relationship with, having the ability to do those asynchronous video visits or communicate through email and actually send across something like, I have a little red mark on my finger. What could it possibly be, right? Having the ability to do that digitally rather than wait until I'm back in town in a week and a half to get that answer has been amazing for me. So I think it's already something I take advantage of. But that being said, I know it is still a very, very small portion of the types of visits that happen today. And so we see that it happens, and it's started to be used in some of those more low risk, easy to understand, situations like something with a very simple dermatological question, right, where you can take a picture, particularly with these really, really high quality cameras we have in our pockets, you can actually get a pretty good understanding of what's going on.
But and here's the risk around that, not to cut you off, but where a lot of industries you do that and you wouldn't worry about it, but with HIPAA compliance and regulations, I mean, it is so onerous for us to be able to for physicians to text each other. If you look, there's 17 identifiers that it's considered PHI, and some of them are ridiculous. The MRN, my medical record number in our electronic health record, is considered PHI. It's not even, it's easier to tie somebody with their social security number. So, these regulations are really onerous. So send in those pictures. If there's a breach, that's a HIPAA violation.
So let's talk a little bit about that. Go ahead.
I wanted to add, though, so this question of remote, that's certainly valuable, and asynchronous, so I can send a message, he can answer later, that's valuable. I think the real equation is asymmetrical, meaning I'm going to create a pile of data that has nothing to do with that visit. Today, my doctor only cares about my body the moment I'm sitting there in front of him, and then I go away for a year, and he doesn't give a shit, and I don't give a shit, and then we come back and we talk again. What I want is a relationship with him that's persistent, where they have the ability to constantly read a story about how I'm doing, and can decide, hey, you need to come in this week, not the regular, forget the regular appointment. In fact, we're going to call you with anomalies. We're looking at you all the time. So it's, to me, it's asymmetrical.
Thank you. So Matt, let's go back to you. You talked about, earlier in your comment, one of your comments, you mentioned that about regulation being artificial, an artificial barrier.
Right.
But you also just touch upon the barriers of regulation. So that is one of the most, one of the challenges that we face in healthcare regulation.
Yeah.
And how do you balance innovation and while operating in a highly regulated environment in healthcare? And what can we do to lower the barrier or to work together to minimize the barrier in healthcare?
I was on a panel with a couple of very well-respected CIOs the other day of very large healthcare systems, and they were both optimistic that we would have less regulation. And I told them I was more confident that I would have an Iron Man display before we had less regulation. I don't want to opine on politics, but that's what it's going to take. Is it's going to take some regulatory reform. If we're serious about changes in the cost, we're going to have to take some of that burden off. The PHI, the HIPAA security rules are ironic to me because, there's sites like Patients Like Me and, Facebook support groups for people that have an illness. Most patients, when they have a very severe diagnosis, the first thing that they do is post on Facebook, I have this very severe diagnosis and I'm looking for insights and referrals and all that type of thing. But Lord, if we were to do that, we'd be fine. And so it's, changing attitudes. Changing attitudes is hard. But I think that's what it's going to take.
I think Ashwin has a different thought on this.
Yeah, I think it's different depending on who you're talking to, right? For a health system and for an organization like BSW, the regulation impacts hundreds, thousands of people.
Right.
Whereas, my company of 25 people, we know the regulations pretty much going into it, right? And so for us, regulatory hasn't necessarily been that same barrier that it does. So a really, really large system that takes hundreds, thousands of people, and then digital systems, paper systems that need to change in order to adapt to new regulations or adapt to changing regulatory landscapes. For us, it requires more resources and time and energy to build a product for a regulated industry, but you're also behind a barrier when you get through it. And so for us, it's a moat. No one else can copy necessarily what we do once we are approved for use in a particular indication. And so it also forces us as a company to build our product, validate our product, put into our quality systems exactly how we designed our product in such a way that the product ends up being better at the end of the day than something that's hacked together. So for us, I think there are benefits as long as you can amass the amount of capital you need to go through a more regulated development process. But it's obvious that for a larger system that has a lot more stakeholders, it can be pretty onerous.
Any thoughts on that, Mark?
It's onerous, but I think what Ashwin's talking about, this sort of consumer-professional hybridization, is what's breaking the ice.
So I have one last question for the panel, and then I'll turn to the audience for questions. But so we talked a lot about some of the current technologies that have potential for, that already have enhanced the patient experience. Can you each give an example of another technology that you may not have talked about that might be in a development stage that will be a game changer for healthcare 10 years from now, 5 years from now?
I have one, but if I tell you, I have to kill everyone in the audience.
All right, so good.
I'm kidding. That's boy, that wasn't very funny, was it? All right. So yeah, healthcare humor is not a laughing matter. Sorry. The social media guys, y'all might want to start handling that crisis right now. One of the things that we're interested in, honestly, is transport. It seems really mundane, but in some cases you do have to physically be in the same meet space as your provider, right? So I'm really interested to see what's going on with autonomous automobiles. You know, it's funny, what they're saying is that the automobile industry is being shaken right now because the things like Uber, which is of course no longer in Austin, but we were joking about this, right? Uber goes away. Uber disrupts the heck out of this place, and then they go away, and everybody's like, oh my gosh, we'll never survive. And then 8 companies come in the next day, and the disruptor's disrupted, and Uber's not here anymore. But anyway, sorry, I'm getting off track here. The point is, Uber and self-driving cars are totally disrupting the automobile industry. People aren't buying cars anymore. So now, like, people like Ford are working with Uber, and they're working on self-driving cars, and we think that there's a huge opportunity for patient transport, for autonomous vehicles to go pick people up, bring them to their appointments and things like that. So that's one of the things but that's a big capital investment, and that's probably 5 to 10 years away.
I think for me, and this is probably going to be kind of an obvious answer, the diagnostics and testing world, we're at the beginning stages of doing continuous monitoring in areas that are not in the hospital. Right? We're probably one of the first companies that's trying to make that happen in the consumer world for a metric that's traditionally only used in medicine. And so I think that's going to change, right? As we move to doing more self-care, caring in the home, there are going to be products like ours that are worn on the body, products like ours that are perhaps used on a daily basis, whether it's, while you're brushing your teeth, you're also taking a test, right? While you're getting ready in the morning, you're also getting some metrics measured about you. And so we move from glucose to things like your electrolytes to things like your cholesterol on a day-to-day basis. These are the things that I think are going to make us have the ability to get an alert when something is wrong and only deal with anomalies like Mark was saying earlier, and instead of waiting until the symptoms actually occur.
I think the answer is easy as AI. Cannot overstate how profound the potential, not even potential, how profoundly AI is now and will continue to change every aspect of life, and particularly how we treat and manage and understand the human body. Because we'll not only, you look at a doctor and his understanding is through conversations with other doctors, his education, reports that he takes the time to read, and his own patient population. But imagine the entire planet's population can be part of his decision matrix. And that decision matrix isn't his alone. It's the decision matrix of every other doctor who's ever dealt with that data coincidence. And that data coincidence isn't simply a human decision, but a set of found factors through this probabilistic logic in the code. So it finds things that people haven't thought to look for. And when you combine all of that, it's easy to imagine a profoundly different way of addressing the human condition. So,
Thank you. So now I'm going to turn to the audience. Please stand up and share your question. Go ahead.
Should I go over here?
You can.
I can shout.
All right.
There's a microphone. That's fine. Thank you. Come on up if you have questions.
First of all, thank you. It's a very interesting panel. The William Gibson quote that you said, where the future is here, it's just not evenly distributed, seems to be the bottleneck. It would be the bottleneck. All the things that you're talking about are great for people in this audience. It's fantastic. We're all here because we're all interested in it. And those 5% that you mentioned, and the next 15% are not going to be the early adopters. They're not, for whatever, because they're not interested, because they're not capable, they can't afford it, whatever the reason. So how are all of these things going to become evenly distributed to make a difference to the system?
So, good question, yeah. Like I said, I think there's 4 factors that you can change the way people behave. We're going to have to either hit them in the pocketbook or something, right? So it's got to be worked into the cost of care somehow. And so, you see more at-risk and bundled payments and things like that. If they need to have that intervention, it's going to have to be worked into that payment model.
Yeah, the one way we're thinking about it is actually, given that the folks that have, for example, in our world, have issues with management of sugar, meaning pre-diabetics, type 2 diabetics, et cetera, those tend to be lower income folks, and it's harder for them to pay out of pocket to afford a technology like ours. We should go to where they're actually getting their care from and who's actually ended up paying for it. And so it may end up being that the purchasers of the vast majority of our products are self-insured employers or payers rather than the consumers themselves. We're designing it to be really easy to use and really well understood by consumers, but at the end of the day, they need to have someone pay for it. Right?
Yeah, I think that's really important. I think you'll find partners in people like us, right? The weirdest thing about healthcare, in my opinion, it's one of the very few industries where the consumer and the customer are two different entities, right? So the person who's paying for the healthcare, a lot of the times, is not the person receiving the healthcare. And so if those are not aligned, you get bad results. But I think what you can see is, so let's say it is a Medicaid patient. You're starting to see more government programs that we're participating in with like managed Medicaid, managed Medicare plans, and we believe that we do a better job of care coordination than the federal government does, and we have providers aligned to that. And so, the fact that we're getting the payment for Medicare gives us the ability to have a little bit of that PMPM money that we can use on things like that to take better care. So that's where you're going to see some new interesting cost models where it's going to be in our best interest to lower the cost of our population and keep them healthy.
There's no guarantee it happens. That's what's really unfortunate. Technology can be a great cudgel between the people who have and people who have not, and it's showing to be that right now. And so unless something changes, it'll continue to go down that road. There's nothing about this tech that suggests even distribution.
Please. Hi, good morning. My question's fairly similar, but about the industry as a whole. Whose role is it to innovate, particularly in an industry where workflows are so important? I think in the Google Glass example, sure, some surgeons are going to adopt that, but then you've still got other surgeons that's taking away time from surgeries they can schedule if they have to learn a new process or a new function.
Yeah, so I'll take a shot at the Google Glass thing, because actually the biggest adoption we've seen in Google Glass in healthcare is actually for remote scribes. So the physician's visiting with you in person, and they've got Google Glass on, and there's someone behind them in a call center who's logged into the medical record, and they're logging everything that's interacting, right? So it's basically, it's just like the scribe that a lot of physicians have that sits in the room and writes down everything, but it's a real time saver for them. So that physician's not touching the keyboard, and they can ask questions, hey, what was their last A1C measure, whatever. And so you see adoption like that. Whose responsibility it is, I'll tell you right now, there seem to be a lot of venture capitalists who think it's their responsibility. There's also, in my opinion, there's almost an irrational exuberance around the health IT industry in terms of making money. There's billions and billions and billions of dollars going into health IT right now. And it's exciting for us, but I swear if I get one more call from a big data analytics, cloud connected, I'll kill myself. There's, a platform. Yeah, there's like, if you string together 4 of these words, I immediately hang up. So, but those are the people that think it's their responsibility to innovate.
Yeah, I would say it's, there's so many stakeholders in healthcare that everyone has some responsibility to innovate in some regard, whether it's the health plans or the payer systems that have to just take a long view on, okay, if we invest a little bit of money now or a lot of bit of money now, we're going to end up saving some time, energy, and producing better results for the care of our patients in the long run. It's hard to do that in the moment when most of healthcare is done on in the moment and decisions are made immediately, but that's one part of it, right? So it's the responsibility of the technologists like myself to think about exactly what the impacts are on the workflow of the physicians that are actually delivering the care and design the product to actually work without having to completely change how they do their jobs. And then venture capitalists obviously throwing money at things doesn't hurt.
When I started working in the design industry, when we had a healthcare project, it was the deep tech that you only saw in the healthcare industry, and we only dealt with people who were in that really vertical slice of the breadth of what product design does. For example, we created a test strip-based glucose sensors, and everything inside of that was pretty much industry-specific tech. And now, I worked with Ashwin last year on his product, and That tech is part of a greater sort of normalization of innovation that's going on across the consumer tech that sort of bleeds all the way into healthcare. And that to me is a fantastic long tail now of sensors getting born out of specific industry needs that become sort of a generalized sensor. They show up in a consumer product, they make millions of them, the price goes to the floor, and then you can come up with clever new uses for it or twists on it and introduce another specific industry-based solution. It's a beautiful system now. So the responsibility is, as Ashwin said, it's a breadth of people. But I'd say the major change to notice is the fact that long tail exists. It's pushing things that are sort of normalized in the consumer side of things up into more professional uses. It used to be somewhat of a separate world, and you didn't see a lot of crossover.
Do we have time for another question? Yes? One more? Okay, please.
Cool. So, excuse me, Matthew, you spoke about the need to get healthier people in the system to offset the cost of that 5% who are creating the cost burden. And I think the panel spoke a little bit about needing to have doctor touch points that were happening not just in moments of crisis, but when people were healthier. And to me, that speaks to the idea of preventive medicine, right? This technology monitoring is a certain kind of preventive medicine, right? And you also have preventive strategies like meditation, which proves to reduce stress, heart disease, all of these kinds of things. I've noticed that insurance companies seem to have a hard time buying into the notion of paying for preventive medicine. Can you speak a little bit to that process and of maybe trying to push toward a world in which more preventive strategies are helped be paid for?
Yeah, so insurance companies are a little bit like Vegas, right? They're in it to win it as well. And I think that's the great thing about someone like us that has we're healthcare, but we have a payer as well. So we have a financing arm. So I think what you're seeing is more experimentation in payers like ours, because we are more collaborative with the physicians. It's not that conversation that most payers have with providers. We're much more collaborative. We work together, and so we're more willing to try things that may or may not have the ROI or the IRR that a large for-profit national payer would want to see before adopting it. So I think they're going to be the last to move in some cases, but it just comes down to financial models, frankly. Are they seeing that experiment or that change is causing a decrease in cost of care? And that's some of the areas that we're going right now. Our clinic over here actually has, I think they have, Nick, correct me if I'm wrong, they have aromatherapy and massage. I know they have massage, but I think they do aromatherapy. So there's things like that right now, that's cash, right? Because nobody's going to pay for that. But in the future, those types of things, if they do have preventative outcomes, you'll see our health plan paying for those preventative types of things. I'm not promising we'll pay for aromatherapy, but in the future, who knows?
Well, we are at the end of the session, and please join me in thanking our panelists for their insights. And thank you for being here. Have a good afternoon.
Thanks.